Welcome back, everyone. In part 50, we wrapped our heads around the pregnancy and newborn DRGs. But today, for part 51, we're diving right into the very core of the MSDRG system, putting a massive spotlight on MDC 16 and 17, that's blood and immunological disorders, as well as myeloproliferative diseases. Real quick, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decoded Healthcare with Harshal. As your lead instructor, I can promise you this. Understanding this exact framework is absolutely crucial. It's literally the ultimate key to capturing the true, real-world severity of your patient's conditions. So let's jump straight into this explainer and see how documentation specificity directly drives hospital reimbursement. Here's our roadmap for today. We're going to quickly decode the MSDRG system basics, untangle principal versus primary diagnoses, look at CC and MC severity tiers, break down present on admission rules, explore the sheer power of clinical specificity, and wrap up with compliant CDI query standards. All right, Section 1, Decoding the MSDRG system. Let's start with the absolute foundational mechanics of how hospitals are actually paid for inpatient stays. Because honestly, before you can even think about optimizing your coding or documentation, you've got to understand the mathematical engine driving the whole shebang. Okay, so the crucial point here, the thing you've got to remember is this core formula. A hospital's payment is simply its base rate multiplied by the relative weight of the assigned DRG. Now, the base rate, that's just a fixed dollar amount set by CMS. But that relative weight, well, that is 100% dependent on your clinical documentation, meaning any shift in that relative weight drastically changes the final revenue. It's a huge deal. But before we get ahead of ourselves, we really need to define the MSDRG itself. It's basically a statistical system that groups inpatient stays with similar expected resource consumption into roughly 750 distinct payment categories. This system forms the absolute backbone of the inpatient prospective payment system used by Medicare. Every single DRG represents a specific group of patients who are clinically similar and require a similar amount of resources to treat. So, let's see how this actually builds out in practice. The MSDRG grouper logic engine filters every single case through exactly 3 steps, all based on diagnoses and procedures. Step 1, it assigns a major diagnostic category, or MDC. There are 25 of these in total. For instance, MDC 16 covers blood and immunological disorders, like sickle cell crises or aplastic anemia, while MDC 17 covers myeloproliferative diseases like leukemias and lymphomas. Step 2, it splits the case into a medical or surgical partition. For MDC 17 patients, this is massive. It separates something like basic medical management of neutropenic fever from highly complex, high-weight surgical procedures like bone marrow transplants. And finally, Step 3, it assigns the final DRG triplet based on the overall severity. Moving on to Section 2, Principal versus Primary Diagnosis. Now, we really need to clarify a critical distinction here, because it trips up so many coders and clinical documentation specialists. And honestly, getting this wrong derails the entire DRG assignment right from Step 1. This comparison brilliantly illustrates why you absolutely cannot just code the patient's symptoms. The primary reason for admission is just the chief complaint on day 1, like, say, severe fatigue and bruising. But the principal diagnosis? That is the condition established after study to be chiefly responsible for the admission, like acute myeloid leukemia. The principal diagnosis is what determines the MDC. So if you just code fatigue, your DRG is going to be completely incorrect, the hospital will be massively underpaid, and worst of all, the patient's true acuity is totally lost. Section 3, Severity, CCs and MCCs. Okay, once that base principal diagnosis is locked in, we have to look at the variables that adjust the severity and actually determine the final payment tier. This is where secondary diagnoses come into play, specifically complications or major comorbidities. These are what push the patient into higher paying tiers based on the extra resources they require. The grouper creates a triplet for almost every DRG. If there's no CC or MCC, you're at the lowest tier. Add a CC and it moves you to the middle tier. But an MCC, that jumps you all the way up to the highest payment tier, which directly reflects the massive increase in resources needed to treat that much sicker patient. To give you a bit of context here, a CC might be something like a simple nutritional anemia or malnutrition, but an MCC, that represents highly severe conditions. We're talking sepsis, acute renal failure, or in our MDC 17 cancer patients, severe complications like tumor lysis syndrome or sepsis secondary to immunocompromise. Capturing these specifically, like documenting the exact remission status of leukemia or specific cell types, is exactly what dictates that final high-tier payment.
Which brings us to Section 4, Present on Admission, or POA rules. Now, just having a severe diagnosis written down in the chart, that isn't quite enough. We actually have to pass the hospital detective test.
You see, every single inpatient diagnosis requires a present on admission, or POA, flag. This just indicates if the patient literally walked through the door with that condition. We use Y for yes, it was present, and N for no, it developed during the stay. We also have U for when the documentation is insufficient, W for clinically undetermined, and 1 for conditions that are exempt from reporting.
So, I want you to ask yourself this. What happens if a patient develops a severe complication, let's say severe pancytopenia, after they've been admitted? Does the hospital get paid more for treating it? I mean, it's an MCC, so logically it should bump up the weight, right?
Well, the answer is no. Absolutely not. CMS will not increase your DRG relative weight for a condition the hospital effectively caused. These are known as hospital-acquired conditions, or HACs. If a complication has a POA flag of N, the grouper completely ignores it for the purpose of a payment bump. And honestly, your facility might even face a quality review penalty. This right here is why capturing accurate POA flags from the provider the moment the patient is admitted is absolutely vital. All right, Section 5, the power of clinical specificity. Let's look at a real-world case study to really see the tangible financial and clinical impact of vague versus specific documentation. Notice the stark contrast between these two approaches. On one hand, you have vague documentation, unspecified pneumonia, and simple diabetes, dropping the case into DRG 195. But on the other hand, by just clarifying that the primary infection was actually sepsis, maybe secondary to an immunocompromised state, and specifically linking the patient's diabetes to ketoacidosis, that same patient is grouped into DRG 871. This specific clinical picture more than doubles the relative weight. Remember, it's the exact same patient in that bed, but the specific documentation finally reflects the true cost and effort of their care. It's a game changer.
Moving to our final section, Section 6, Compliant CDI Query Standards. Because when documentation is missing that level of specificity we just talked about, clinical documentation integrity teams have to step in and bridge the gap using a formal query. But there are strict rules here. You can't just ask for the answer you want. For example, regarding MDC 16 blood disorders, if a patient's hemoglobin suddenly drops, you cannot send a leading query asking, "Hey, can we code this as acute blood loss anemia?" No way! That is a massive compliance red flag. Instead, you have to use a non-leading query, something like, "Can you clarify if the anemia is acute, chronic, or due to a nutritional deficiency?" You must present all clinically reasonable options to the provider, and that includes the option that results in absolutely no change to the current documentation. Understanding these DRG mechanics really empowers you to ensure every chart reflects true patient severity. Next time, in Part 52, we'll be tackling MDC 18 and 19, infectious diseases and mental health disorders. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Until then, I want to leave you with this thought. As you evaluate your own facility's practices, ask yourself, is your documentation truly telling the full story, or are you leaving critical revenue and clinical accuracy on the table? Thanks for joining me, and I'll catch you in the next lesson.